quickly grab a glass of water. Oh, no, never mind.
Hi. Thank you everyone for joining us for this Becoming a Doctor tutorial. This one will be on acute abdomen, hosted by Dr. Kanchana Niruttan. As always, house rules: if you're in the Zoom chat, feel free to type any questions in the comments in the chat. And if you have any questions that can wait till the end, put it in the Q&A box. And otherwise, I'll hand it over to Dr. Kanch.
Hi there. Hi, I'm Kanch. I'm an F2 in East Kent, and today I'm going to go over a little bit about the acute abdomen. So surgery is obviously incredibly broad, and essentially I was hoping to focus on kind of managing the acute patient who comes in through A&E and really focusing in on how your initial assessment and the kind of the tests you do, and then your differentials. So this is sort of a disclaimer that Ehsan has made me put up. But essentially this is not medical advice, it's a tutorial. Yeah, and so these are sort of the learning objectives for today. So we're going to cover the initial assessment, we're going to cover some of the management, some of the differentials. We'll touch briefly on some of the anatomy, not very much of it. And then we'll go into a couple of specific pathologies. I was hoping to cover kind of the stuff that can go horribly wrong, really, the kind of pathology that needs theatres quite quickly. And then we'll round off with a couple of EMQs and some questions. Yeah. Does anyone have any questions off the bat or anything they'd like to do? They'd like to clarify before I start? Feel free to message me. Oh. All right. So, sorry. So a patient walks into A&E, and they come in and they say, I've got abdominal pain. And you kind of think, and you're told, okay, you're going to go assess this acute abdomen. So the definition of the acute abdomen is sudden onset, severe abdominal pain of less than 24 hours duration. So if it's a little old lady who's been having constipation and tummy aches for 3 months, not quite what we're covering here. And really the first thing you want to do is make sure the patient isn't dying. So you want to make sure that they are safe for you to then go on and do a thorough, meaningful assessment. But there's a couple of kind of things that you should do first before you kind of go to see these, before you kind of start really digging into the assessment. And the first thing is, when they come to A&E, they will have had their obs done. So they would have had, you would have at least kind of one set of observations. So look at them, check on the news score, check if their blood pressure looks okay to you. Is it a young, fit 20-year-old who's coming with a systolic of 90? Then maybe you might want to start to worry a little bit. Does the heart rate look normal to you? Are they saturating appropriately for kind of what you know about them? And those are things that can already direct how kind of urgently you want to see them, how urgently you want to kind of be thinking about escalating them, whether you want to be calling a red straight off the bat and saying, I'm a little bit worried about this person, I'm going to go see them, but you should know that they're here. So you go and see your patient, and again, a quick A to E, particularly if you're on sort of things like recess and they come in quite unwell. Depending on how far along med school you are, you'll have had this kind of drilled into you to various degrees. But the A to E essentially goes over, I'm assuming most people are here third years, so I'll quickly run through the A to E, but the A to E essentially is airway. So can they maintain the airway? Is there sort of vomit or their tongue kind of obscuring, kind of getting in the way of the airway? Is there something you can do to alleviate that? B is breathing. So check your SATs, auscultate the chest. Is there anything kind of obvious that you can find there? C is cardio. So you want to do a couple of things with cardio. You want to check on their blood pressure. You want to check on their heart rate, and you want to check on you want to consider a couple of things at this point. So when it comes to cardio, you can kind of consider putting in your large bore access at this point. If they're really unwell, you might want to consider putting in a catheter at this point as well to monitor their urine output, particularly if they're going to theatres imminently. Then D is disability. So there's two big components to disability, which is your pupils, make sure they're equal and reactive, and a GCS. And E is exposure. So expose the patient, maintain dignity, obviously. But you want to check for kind of, in the context of the acute abdomen, you're looking for kind of obvious bleeding, potentially signs of melena. Oh, we got a question here. Oh, never mind, sorry. And then, yeah, so E, expose them, or and look for kind of bits like rashes and that sort of thing. Yeah, it may seem a bit obvious, but every once in a while you kind of, you see someone and you're not quite sure what's going on, and then you expose them and you realize, actually, there's a big pool of blood that we haven't seen before. And then there's DEFG, which is don't ever forget glucose. So easily missed, but also so easily corrected. So DEFG. And check on their GCS. So consider what's normal for them. So are they perhaps someone with known cognitive impairment who doesn't always hit 15 on 15? Or are they someone who's young and fit and, you know, going to lectures the day before? Yeah, a GCS assessment is worth doing. And again, all of these things will inform how rapidly you want to assess them, how urgently you want to get tests done, how much you want to kind of push for senior involvement. And it all allows you to kind of prioritize how you want to manage your patient. So, so you've done your end of the bed and you're happy that they're stable enough for you to have kind of do your history and examination. So I imagine you all know how to do a medical how to do a history. I'm just going to run through a couple of things that are important to remember in the context of a surgical history. So pain. So Socrates the pain. That's really helpful. And it gives you a lot of information, actually. So site gives you a lot of information about that. Just the site alone, knowing the S alone of Socrates, the site, gives you a lot of an idea of what you want to be considering. And we'll run through that in the next slides, actually. And then you want to look through, you know, onset, character, radiation, all of that stuff. And then you want to move on to a couple of kind of specific abdominal symptoms. So nausea and vomiting. That could suggest potentially things like pancreatitis or altered bowel habits. So things like melena might suggest potentially a bleeding ulcer. Things like constipation might suggest might give you a precipitant for potentially sigmoid volvulus. So check on bowel habit, very important. And then do a bit of a systemic screen. So things like jaundice and fever, weight loss. Check for history of reflux. And a couple of extra bits are previous surgical history. So that's really helpful. That's actually incredibly helpful because if they've had a history of surgery, they're more inclined to have adhesions and potentially more at risk of bowel obstruction. And the other thing is if they've got kind of an obvious little gridiron scar, or they've said, you know, I had my appendix out, then maybe they don't have appendicitis. And in a young woman of childbearing age, always do a pregnancy test. And there's two reasons for this. On one hand, it informs you differentials. So, you know, potentially ectopic pregnancies, potentially gynecological pathology, but it also informs what kind of tests you would do. So in a young woman of childbearing age, you wouldn't be running off to do a CT scan, but if they were pregnant, you really wouldn't be you'd really want to try and avoid doing things that expose them to radiation, expose them to X-rays rather. So kind of young women always remember to do that test, to ask at least. So this was a really good picture. This is a picture that I really liked from Teach Me Surgery, which is actually a really good website for revising for surgery. I used it for MRCS as well. But essentially it kind of divides it's talking about the regions in the abdomen and what kind of pathology you would expect. I think the one thing I think is important to be very aware of is that to remember the extra GI causes of abdominal pain. So things like MIs, things like pneumonias, obviously the reproductive organs, and UTIs and pyelonephritis, they're all kind of things that that you do need to keep on your radar, and that actually quite a lot of the time OSCE examiners do like to bring up. So do keep them in mind. But other than that, it's a fairly self-explanatory diagram. So based on kind of the positioning based on the site of the pain, you could there's kind of characteristic sites that would suggest certain underlying pathologies. So like diverticulitis in the left iliac fossa, or appendicitis classically in the right iliac fossa. Things like cholecystitis, gastric ulcers, and then kind of epigastric pain, so pancreatitis, or periumbilical pain in the periumbilical region. Things like appendicitis initially present as periumbilical pain, and this is to do with referred pain. We'll touch on that very, very briefly, but it's essentially to do with how pain refers from the visceral pleura and radiates to a dermatome. But obviously it's something you can revise kind of off a textbook. This is a more detailed diagram. I thought it was a good diagram to have on the slides. If you're looking at the slides to revise later on, I'm not going to go into it in detail, but I did think it was very comprehensive. And again, I'm not going to go through all of the examination, but there are things that you want to look out for when you're coming in to kind of assess a patient who's come in with an acute abdomen. So do they look so just kind of do the end of the bedogram. Do they look pale? Do they look clammy? Do they look like they're in obvious discomfort? Oops, sorry, appears to be a question. Oh, okay. So we've got a question saying, oh, so I've got a couple of questions here, sorry. One was, do you mind explaining differences in color format? So let's pop around to, so there's a couple of things that you look out for in the color format. So one would be bilious vomiting that would potentially suggest kind of bowel obstruction classically. So it's a really green, so you'll see it on the wards, it's just really kind of very bright green kind of vomit that they're bringing up. So that would suggest small bowel obstruction quite often. Another thing you'd want to be looking for is things like coffee ground vomiting. So so it would look like coffee grounds, but that would suggest semi-digested blood that's being brought up. Again, fresh blood would suggest variceal bleeding potentially. Outside of those, there isn't very, so those are the kind of big three when it comes to the color of the vomitus that you'd want to look out for. Then I've got another one that says, hey, can someone cross-check? What are the other important sounds apart from tinkling? So generally, I tend to look out for essentially whether they're present, whether they sound normal, and then kind of in bowel obstruction, you tend to have kind of absent or tinkling bowel sounds. There aren't that many more. You'd probably go on to kind of your history and you'd probably be leading more of your history and your investigations at that point. But it is worth looking up. I wouldn't be able to tell you about other bowel sounds off the top of my head. Okay, moving on to the examination. So have a look at them from the end of the bed. Consider the cardio and respiratory exam, and then do a bit of a peripheral exam. So a couple of things that are helpful here are the cap refill and the JVP, and then move on. So things like, are they obviously peritonitic? Look for scars, and then you want to palpate. Look specifically for tenderness or guarding. I'll go over a couple of the specific kind of eponymous signs that the surgeons love to kind of dig up when you turn up in theatres, but we'll have a quick chat about that. How a feel for the aorta? So is it expansile and pulsatile, or can you just feel it? And any kind of obvious masses? Is there obvious fecal loading? Is there kind of fullness in the right upper quadrant? That sort of thing. And it is a question of practice. So the more you do, the more you'll be able to kind of elicit. Percussive, bar percussing the liver, I've never, and sort of ascites, I've never gotten much more information than kind of the liver looks sort of okay sized and there might be some fluid here, but it's worth doing, and auscultate obviously. So surgeons love, and in OSCEs, OSCEs and kind of EMQs, so they do love digging on these kind of eponymous signs that come up. So there's a couple that do come up quite often. So Murphy's sign, which is when you essentially palpate the right upper quadrant, ask the patient to take a deep breath in, and you have pain on inspiration, and that's a sign of cholecystitis. There's McBurney's sign, which is tenderness on palpation, which is appendicitis. You've got a whole lot of kind of eponymous signs related to appendicitis actually. So you've got the SOAS sign, you've got Roswig sign. You've got you've got rebound tenderness. So they all kind of point towards appendicitis. And there's a couple, so pulsatile mass is important to check for. And Cullen's and Gray Turner, so these kind of point towards generally, classically pancreatitis actually. But Cullen's would be bruising around the periumbilical region, and Gray Turner's is kind of a sign of retroperitoneal hemorrhage. So kind of you would have done your history, your exam, and then the next kind of important thing you want to do in assessing these patients is doing your investigation. So so urine dip gets done on everyone very routinely in A&E. And that gives you quite a lot of information, actually. So it gives you an idea, mainly, do they have a UTI? Because UTIs do present with abdominal pain. But also kind of, is there blood in the urine? Because that would potentially point to, things like kidney stones. Then you'd want to do, in a woman of childbearing age, you'd want to do a urinary pregnancy screen. And you consider an MCNS, a microscopy and culture, if you thought maybe you were really suspecting a urinary tract infection, and you wanted to tail you might want to tail antibiotics later on. If they had pyelonephritis, and MCNS would be really helpful. Do your routine bloods, so FBCs. So you'd be looking for particularly things like the hemoglobin and the white cell counts. Is the hemoglobin very low? Is the white cells really high? You want to look at U's and E's, and that gives you a lot of information on things like the hydration status, the electrolytes, but it also gives you an idea of whether you can give them, send them off for a CT, because whether they can have contrast to go into their CT, because obviously if you've got impaired renal function, then that you worry about contrast-induced nephropathy, for example. You consider liver function, you consider CRP, again, very important. Amylase is sort of a plus or minus. So if you're clinically worried about pancreatitis, you would do an amylase. And generally, if you came in through A&E, you'd get a VBG, which is for the lactate. The big thing that we look at on the VBG is the lactate, really. And that's just kind of an idea of how the patient is coping, kind of generally coping. So if the lactate is starting to creep up, you start worrying that they're not they're not able to compensate for the increased stress of having this infection or a perforation or whatever the pathology is. Or for example, if you had bowel ischemia, then you'd have a really high lactate, and bowel ischemia classically presents with incredibly high lactates, and that will make you worry. The one thing you do want to do with most surgical patients, especially if you think they're going to theatres, is a group and save and a cross match. So those need to be sent off fairly quickly, actually. And I forgot to mention the clotting for quite a lot, because quite a lot of patients will come in with either on anticoagulants, or quite often if they're going to theatres, it's very useful to have a clotting, just to make sure that they're not going to bleed, or not going to bleed excessively. Other things you can consider, an ABG, if they're really acutely unwell, you can consider that. Blood cultures, particularly if you're considering an infection. And then you go on to imaging. So an erect chest X-ray is kind of classically what you would use to, yes, look for chest pathology, but you're also looking for air under the diaphragm. And I should have included a picture, actually, but it's essentially a sign of a perforation of bowel perforation, because essentially air escapes from the bowel and sort of lies just on top of the liver. And you see a very kind of distinctive crescenteric shape just sitting above sort of the liver under the diaphragm. So you want to look for air under the diaphragm on a chest X-ray. Abdominal films have their uses. So there are lots of kind of characteristic kind of things that do turn up on abdominal films. Things like the coffee bean sign in volvulus, things like thumbprinting in kind of in sort of ischemia. You'd see sort of, so there is a role for the abdominal film. Ultrasound scans actually get done very commonly, particularly in young women, where you're kind of a little bit more reticent to do a CT scan, where you're suspecting things like appendicitis quite often. And generally, you have kind of two approaches. In a male patient, it would generally just be an abdominal ultrasound. In a female patient, you would also consider potentially, particularly if you're worried about gynecological pathology, you'd be considering a transvaginal ultrasound, which would give you quite a lot of information about things like the ovaries, the lie of the uterus, or whether there's any evidence of torsion or bleeding in that area. And then you could consider a CT scan. So generally a CTAP or CTKUB, which is the first line investigation if you're worried about kidney stones. But a kind of one of the caveats to that is if you're giving them contrast, you do need to make sure that their kidneys can deal with the contrast. So I'm just going to have a quick look at the questions here. Okay, so so in what scenario would cardio and resp exams be useful? So generally, like I said, quite a lot of kind of things like pneumonias do sometimes present with abdominal pain, so slightly oddly. So it would be worth listening to their chest, seeing if there's anything kind of obviously, if you can hear obvious crackles in there. But also doing a cardio and a resp exam on most patients is good practice, just so you have an idea of their baseline. Having an idea of, are they in fibrillation? Do they seem like they're in fibrillation? Is that something that needs to be dealt with if you're considering maybe going to theatres with them? and resp exam, just to know that they actually, that you know, you've got equal breath sounds, and you know, the lung sounds good to you. That's all quite helpful. It does inform kind of how you see the patient. It does inform the wider context of the patient. But also things like pancreatitis, you'd probably have a bit of kind of you probably wouldn't be actually most patients with acute abdominal pain probably wouldn't be kind of actually taking very good deep breaths anyway. I think the next question says, is lactate a marker of peripheral hypoperfusion? Yeah, potentially, yes. So how would you manage a bowel perforation? So bowel perforations, you would manage a bowel perforation, so it's not always managed with theatre. So quite often it would depend on the severity of the perforation. So minor perforations, minor holes that you'll see in diverticulitis can sometimes be managed conservatively with antibiotics. It is really a decision for a senior clinician. So as an F1 and F2, or even the SHO on the surgical firm, you're probably not going to be making that decision to take them to theatres. But significant bowel perforation, particularly ones that are causing trouble bleeding or peritonitis, would go straight to theatres, generally to a laparotomy and washout. Occasionally, there might be a laparoscopic first look laparoscopy, but generally it would be a laparotomy and plus or minus dealing with the bleeding, plus or minus a washout if there's feculum matter in the peritoneum. The next question I've got is, which tube do you use for the VBG? Yeah, so this is the kind of thing, this sort of thing I did not know when I went into the wards. But a VBG is just done on an ABG syringe, and you run it through the ABG machine, which is why it's very, very useful, because it's really quick results. And it's quite a lot of information quite quickly. So essentially, you take your bloods with a normal Vacutainer, you unscrew the Vacutainer, and then you screw on the ABG syringe. It's a bit of a faff, but you'll get good at it in F1. Oh yeah, and that's it. Yeah, but if any more questions, please keep them coming. So the question I've got is, that's a really good question. It says, why would people still use an ABG if a VBG is the same and less painful? Yes, so the VBG is, I agree, a lot less painful. It gives you some of the same information, but because by definition it's venous blood rather than arterial blood, it doesn't give you kind of things like the PO2, the PCO2. So if you were particularly in rest patients, you wouldn't get that information from a VBG. In kind of the acute surgical abdomen, I do agree that, you know, a lot of the time a VBG is very useful. But if you're worried about kind of chest pathology, if they're kind of in respiratory failure and you need that information, you'd want to do an ABG. Yeah, any more questions, please message me. I'm going to go back to the slides now. So imaging, so we covered ultrasounds, we've covered CTs, okay. And so what goes to theatres? So there's three kind of broad categories of what goes to theatres. And again, so if you go to history, or kind of if you go to kind of the way they're looking initially, and you think, okay, this is someone who might need to go to theatres, you're probably already going to be calling a registrar saying, I'm worried about this patient. And this is one of the things that's really kind of stuck with me in F1 and F2 has been escalate quickly. Because really what you want to do is ensure that your patient is safe. And a lot of the time that means making sure that someone who's senior who can do something to sort things out knows that it needs to be done. Particularly in surgery, where you're not necessarily going to be able to, you're not going to be taking anyone in to do the laparotomy yourself. So making sure your seniors are aware, making sure that they are on hand to help you is really, really important, actually. But there's three sort of broad categories. So bleeding. So the big one is the ruptured AAA. So this, and we'll cover a couple of kind of these pathologies, the ones that can go quite pear-shaped quite quickly. So ruptured aortic aneurysms, but also ectopics, peptic ulcers. Then perforation of a viscus. So they can present kind of acutely peritonitic, particularly if kind of there's material in the abdomen, there's kind of an peritonic an infection in the abdomen. And then ischemia, which we will also cover. So we will cover kind of a couple of the pathology that does tend to kind of go quite bad quite quickly. Just have a look for any questions. No? Okay. So I'm very, very briefly going to touch on the anatomy. But what you have essentially is, so you've got three major arteries that come off the aorta. They're sort of three big non-paired arteries, and they supply most of the GI tract. So the first one is your celiac trunk. So this supplies kind of the end of the esophagus all the way down to the start of the duodenum. The second is the superior mesenteric artery. And this kind of goes from the duodenum down to the 2/3 of the way along the transverse colon. And the third is the inferior mesenteric artery. And this kind of essentially goes from covers the last third of the transverse colon, right, almost up until, and some of the up down till some of the rectum. And a lot of this blood supply kind of goes back to kind of the embryological origins. So essentially, the bits that were supplied by the celiac trunk are the embryological foregut. SMA supplies the embryological midgut, and the IMA supplies the embryological hindgut. And this also has implications for sort of referred pain. So essentially, that you have two bits of peritoneum, the parietal and the visceral peritoneum, but essentially the visceral peritoneum is not particularly good at localizing pain. So if you've got kind of non-specific, if you've got inflammation that hasn't kind of gotten particularly bad, it will irritate the peritoneum, the visceral peritoneum. And essentially pain in structures associated with sort of midgut tend to produce referred pain to the periumbilical region. Kind of referred pain from structures in the foregut tends to go to the epigastric region. And from the hindgut tends to go slightly below, kind of just below the periumbilical region. So that's sort of the basis for kind of this, particularly things like appendicitis, this sort of the basis for why you have abdominal pain, periumbilical pain that then becomes localized into the right iliac fossa, because essentially initially you will have kind of irritation of the visceral peritoneum. And then it sort of starts, then you start having more kind of pronounced inflammation in the region, and it kind of becomes more localized. But again, this doesn't get covered. This doesn't really come up in exams, so I wouldn't worry massively about it. It is. I mean, it doesn't come up very much in OSCEs anyway. So I'm going to cover a little bit of kind of the specific pathology that I thought were useful to go through. That kind of tend to kind of present acutely and can go quite wrong quite quickly. So the big one, abdominal aneurysm. So these can go, so abdominal ruptured AAA is a surgical emergency. Kind of quite often, I think the mortality is about 50% in a ruptured AAA. So an abdominal aneurysm is defined as the dilation of the abdominal aorta to more than 3 centimeters. And you've kind of got the usual suspects when it comes to risk factors: smoking, hypertension, age, gender, family history. So the big thing with abdominal aneurysms is the screening program, and this does get asked a lot actually in both writtens and in OSCEs. So it's worth knowing the screening program. But essentially, in the UK, all men at 65 have a one-off ultrasound scan of the abdomen. And essentially, you get stratified based, if they are found to have an abdominal aneurysm, they're stratified based on the size of the aneurysm. and essentially what you do with them depends on the size. So if it's a relatively small one, 3 to 4.4 yearly scans. If it's a bit bigger, 4.5 to 5.5, you want to do 3 monthly scans because you want to keep quite close surveillance. It's more than 5.5 centimeters, you really want to be thinking about kind of getting them to the vascular surgeons fairly sharpish. The reason you wouldn't send them off straight to surgery, obviously, because quite a lot of patients are amenable to potentially endovascular repairs. So EVARs that are a lot less invasive, have quicker recovery times. So you want them to be seen by vascular at the very least in 2 weeks. Also worth knowing, if you're AAA more than 6.5, no driving for you until it's fixed. So that if you have AAA more than 6.5 centimeters, that requires informing the DVLA. Essentially, there's 3 kind of conditions where you would consider surgery. if your AAA is more than 5.5 centimeters, if it's getting bigger, so if you're under surveillance and it's expanding by more than 1 centimeter here, what's causing symptoms? So a lot of the time it presents with kind of abdominal pain, back pain, actually quite classically. But that is kind of, that would be an indication for surgery. And generally you have two options. So an open repair, which is kind of, which is essentially, well, it's a laparotomy and a repair, or an EVAR is an endovascular approach, which involves an approach via the femoral artery. So as I said, aneurysms can go pear-shaped quite quickly. I've got a question here, just gonna have a quick look. Oh, it says, do you know of the new guidelines from NICE which states preference for open repair over EVAR? Is this clear? I wasn't aware that there was new guidelines to suggest a preference for open over EVAR. My understanding was that they were equally kind of, they should be considered equal, to have equal merits. It's worth looking up. I was not aware about new guidelines. Thanks. So ruptured AAAs. So generally, they're going to be incredibly, they're not going to look well when they come in. They're going to be hemodynamically very unstable, tachycardic, hypotensive. GCS is not likely to be, you know, they might have a dropped GCS, significant abdominal pain, classically tearing abdominal pain, radiating to the back. So 20% tend to rupture anteriorly, 80% rupture posteriorly, and you want to manage these patients really, really quickly. So if you're worried, so they typically come into the resus bay, you'd start them on, so everyone who's really unwell gets started on high flow oxygen, you'd want wide bore cannulas, blood's running off, and you want to cross-match at least 6 units, if not more, because they're going to need a lot of blood. The other thing they're going to need is transfer to a vascular unit, because you can cross-match all the blood you want. If there is no vascular surgeon around, there's very little you can do. So you want to immediately transfer to the vascular unit. Ideally, they'd be going straight to the vascular unit if they were triaged in an ambulance. And then you want to consider at which point, if they hit the vascular unit and actually they're stable, then they'd consider doing a CT angiogram. So this would essentially look for the region of the where specifically in the aorta there is a rupture, and whether it could be managed with an endovascular approach or whether it needs open repair. If they're unstable, you don't wait for a CT, straight to theaters, and they try and repair it there. Oop, I've got a question. The question says, no, so you wouldn't be giving these guys beta blockers, no. Yes, sorry, I did not mention permissive hypertension. So sorry, the question says, would blood pressure control be with labetalol? Not necessarily, but essentially this idea of permissive hypotension is this idea that if you get there, if you resuscitate them almost too well, you run the risk of dislodging clots that may have formed that may be tamponading the rupture. So what you want to do is aim for what they call permissive hypotension, which is a state of being slightly hypotensive to minimize the risk of dislodging these clots. You wouldn't always be giving labetalol, no, but I don't think it would necessarily be with labetalol, actually. Sorry. So yes, so that's AAAs. The next one I want to go through was peptic ulcer disease. So again, these can potentially present with bleeding, particularly if you have a peptic ulcer in sort of the duodenum that can erode backwards into the gastroduodenal artery. These classically bleed quite significantly, and people can be quite unwell. But essentially, the big risk factors are H. pylori and NSAIDs. But essentially, they can present with pain. They might have had a background of reflux or reflux-like symptoms, abdominal pain. And your investigations you want to tailor to your patient. So not everyone needs, so a peptic ulcer is technically an endoscopic diagnosis. That doesn't mean everyone needs an endoscopy, because you want to balance the risks and benefits of the procedure. So in a young patient who's got minimal risk factors, who looks like, who you're not particularly worried about it being something kind of malignant or sinister, you're not necessarily going to run to do an OGD on them. But you would consider on the first line non-invasive H. pylori testing, because that's something that can be managed quite easily, particularly if it's an older patient, particularly, and you're starting to see red flag signs, so maybe some melena, maybe some weight loss, maybe some wasting, things like that. You definitely want to refer them down for endoscopy, fairly sharpish, actually. Management, again, is generally conservative, so lots of lifestyle stuff. H. pylori is managed with something called triple therapy. So it's 2 antibiotics and a PPI, a proton pump inhibitor. So that's your omeprazole, pantoprazole, lansoprazole, that sort of thing. And surgery is rare, so it's either for things that are kind of acute, so acute perforations, if they come in, acutely bleeding or perforated, or for things like Zollinger-Ellison syndrome, which is a gastrin secreting insulinoma. It's incredibly niche. We had one on our ward, but it was because it's St. Thomas's, and it was sort of this tertiary center, and we had these weird, wonderful kind of conditions come in. But surgery is fairly rare for peptic ulcers, unless they present acutely. Bowel ischemia is kind of another thing that presents very acutely, and will generally need surgery fairly quickly. So there's kind of the two big things that can cause it are thrombus in situ or an embolism. So a thrombus in situ is essentially atherosclerosis that builds up and eventually completely occludes the arterial supply to a segment. An embolism is essentially thrown off, generally by something like AF, which would then cause you to have kind of a sudden onset ischemia. People with thrombuses in situ generally tend to be kind of arteriopaths. They tend to have had maybe kind of evidence of maybe some abdominal angina in the past, whereas embolisms tend to present fairly acutely, fairly quickly, fairly unexpectedly. If you're suspecting someone with an embolism, then you do want to check for things like actually whether they're in AF currently, that sort of thing. Are they anticoagulated at all? Sorry, I've got 2 questions here that says, it says, how competitive is guys in St. Thomas's for FY? I mean, I got in, so not very competitive. So the cutoff in my year for South Thames was 82, and there were quite a lot of, it's a big hospital, so there's lots of jobs. So, if you're in South Thames and you have a decent chance of getting a guy's or a king's job, to be fair. Yes, so the next someone says, could we please talk through the differences in ischemic colitis versus mesenteric ischemia and acute diverticulitis? Okay, so acute diverticulitis is a different kettle of fish altogether. So diverticular disease is essentially outpouchings that form in the mucosa of bowel. It classically presents in sort of the sigmoid colon, and essentially acute diverticulitis is inflammation of these. Oh, sorry. I've got a message from Ehsan saying maybe say I'll answer this at the end. Sorry. So we'll come back to that at the end. Sorry. And now he says don't read out my comments. Okay. We'll come back to a couple of the questions at the end. Yes. So bowel ischemia. So essentially, they come in with generalized abdominal pain. The pain is out of proportion to the clinical findings. And I've only ever seen proper bowel ischemia once. And the patient did need to be transferred very, very quickly. And ultimately we weren't able to, he passed away later that evening. But it presented a significant, absolutely kind of, you could see it, he was in absolute agony. And it had come on incredibly quickly. And we sort of essentially within the space of about 15, 20 minutes, we were escalating right up, right down to the consultant really. And so in this case, you really want, this is a case where you want a VBG particularly, maybe not necessarily an ABG, but the big thing you want to know is the lactate, because in bowel ischemia, the lactate shoots right up very, very quickly. You want the bloods going and you want to cross-match. You want to cross-match and you want them ready for theatres, because you do want them, with bowel ischemia kind of time is bowel really. So the longer you wait off, the longer, the more bowel is likely to die. Essentially, they go into theatres, it would be laparotomy, and it would be resection of non-viable bowel. If you're in a really good vascular centre, there might be some options for revascularization. Generally, it tends to be resection of kind of necrotic bowel, though. Yeah. So the next one I want to go through was pancreatitis. So this is the pancreas from this comic called The Awkward Yeti. But I'm sure you've so pancreatitis is one of the slightly odd ones in that it counts technically as a surgical condition, but it's generally not managed surgically. So when we were in our surgical firm, we have lots of pancreatitis patients. The surgeons would just seem a little bit frustrated that they can, take them into theatres and do something about it straight off. But essentially, it's exaggerated activation of digestive enzymes in the pancreas. And what you're going to see is severe epigastric pain, sometimes radiating to the back, nausea and vomiting. They'll come in, they'll be, they present as in a lot of pain. They generally, their lactate will be slightly elevated. And you want to do the big investigations you want to do, amylase, the LFTs, and the lipase. Amylase because, because that's what's most commonly done. So an amylase more than 3 times the upper limit of normal or greater than 1,000 would suggest pancreatitis. Lipase is actually more specific than amylase. The reason it's not done more often is that it's quite a lot more expensive. So amylase can technically go up in quite a lot of other pathology, but lipase is a lot more expensive, so we do amylase instead. Imaging you would absolutely consider. So if you go up to our I get smashed mnemonic, that everyone knows off by heart clearly, gallstones, you want to know what the cause of the pancreatitis is. And particularly if it's gallstones causing pancreatitis, you want to be planning for a cholecystectomy down the line if it's causing sort of problems like that. So an ultrasound scan is very useful. Sometimes you wind up getting a CT, and you'll have CT, you'll have evidence of CT provided evidence of pancreatitis. So essentially, the way it works with pancreatitis is you need 2 of 3. You want clinical evidence, biochemical evidence, or imaging to suggest pancreatitis. So 2 of 3 will give you will allow you to make that diagnosis. And the management is not actually that complicated. It's lots of fluids. It's analgesia because these patients are often in quite a lot of pain. Occasionally an NG tube and a catheter. The theory with NG tube is the idea that you're resting the bowels, by keeping the nil by mouth and so the NG tube, it would be more a Ryle's tube actually, but essentially a lot of the time they are kept nil by mouth, with the theory being that you could rest the bowels. You generally wouldn't be giving them antibiotics unless you had a confirmation of necrotic pancreatitis. Run-of-the-mill pancreatitis does not get antibiotics. So there's one of the Glasgow scale, which is what I have up here on the right hand side, is something that does come up quite a lot. So it's got a handy mnemonic pancreas, and if you go through it, you'll notice that the one big thing that it doesn't take into account is amylase, the test that we all do at the start when we're looking for pancreatitis, and that's one of the things that they do try to catch you out with a little bit. But so you don't need to know all the values off by heart, but it's worth knowing what's in the scoring system. So, sorry. So appendicitis. So this is fairly rare. This is just, I'm putting it in because it's quite common, but luminal obstruction, generally with the fetal lip. Generally younger patients, they'll present with periumbilical pain, going to the right iliac fossa, generally be a bit pyrexial prior to this, maybe some vomiting, maybe some kind of raised leukocytes. Definitively, so you can manage it conservatively actually, and we do occasionally see people who decline surgery who are managed conservatively. And they do reasonably well actually. But definitive treatment here is a laparoscopic appendicectomy. It's a fairly quick procedure. People go home the next day. It's fairly well tolerated, actually. Obviously, the appendix up there. Yeah, so that was it. So essentially, I was hoping to do a quick run through of kind of common things that come up, or common things that go wrong, really. That could go wrong. That could come up that need urgent surgery. So I've got a couple of questions to finish up with. Anyone have any more questions? Let me look. So I've got a question here that says, what is this scoring system called? It's the Glasgow scoring system. It's the Glasgow scale. Yeah, not the Glasgow coma scale, there's also Glasgow pancreatitis scale. Okay, so we're going to move on to questions. I don't have very many, but we'll move on to some kind of EMQs and SBAs, and then we'll have a bit of time at the end for questions. So the first one I have here is, so this is the only EMQ I have, but essentially we're trying to match the source of pain to what the pathology potentially is. I appreciate that I haven't actually gone through a lot, all of these with you. So there's no pressure here. I will open the poll though in a second. So I'm just going to run the test poll first, if everyone's all right with that. So I'm going to run the test poll. If everyone could reply to it if you want to. Our panelist. Relaunch polling. Continue. Sweet, so it works. Lovely. Okay. So I'm going to end that because it works. People seem to pick A. So let's go to the second question, which is source of plane. So yeah, so essentially it's we'll give you we'll put up the where the pain is radiating to, and tell us where you think what you think the pathology might be. So is everyone able to reply to this? See, I've got something on the chat that says everyone can reply. Perfect. Oh, Esan says give it 2 minutes. So I'm going to close down the poll in about 30 seconds, if that's okay, guys. No pressure to answer. If you feel like you want to, that'd be lovely, though. Okay, so I'm going to close in the poll and we'll put up the scoring up here. So I'll share the results. Okay. And the problem is okay, yeah, I can see the results, I think. So I'm just going to flip around to the answer slide. See if I got this. There we go. Yeah. So pancreatitis, so back. So we've got quite a majority of people have said pancreatitis, radius to the back, absolutely. So the umbilicus and appendicitis, brilliant. So 75% if you got that right, that's brilliant, yeah. Low angle of the scapula. So yes, so this is referred pain potentially. So the thing with, so this is potentially referred pain. So it's sort of secondary to kind of irritation of, this is sort of referred pain from cholecystitis. Then you've got loin pain, which is urinary colic. Everyone's got that. Perfect. Groin pain, testicular pain, lovely. Oh, sorry. Oh, sorry, I think those have been flipped over. So urinary colic needs to be loin pain and testicular pain needs to be groin pain. And yes, absolutely, splenic rupture would be specifically to the left shoulder tip. And this is down to irritation of the diaphragm. So you'd have splenic ruptures classically bleed profusely, and what you would have is blood irritating the diaphragm. And diaphragmatic irritation classically radiates to the shoulder tip. And again, on the left-hand side, which correlates to where the spleen is. Yep. So shall we move on to the next question, unless anyone has any questions? Okay. So the next ones are just SBAs. Put up the next slide. And put it up here. So I think we'll give this maybe a minute, and I've launched the polling. But essentially, which of these parameters would not assess the severity of the pancreatitis? And I've got a question here that says, oh, no, never mind. So I'm going to end the polling and sharing the results. So most of you got that right, absolutely. So I think a couple of people said calcium. So remember, so the mnemonic for the Glasgow score is pancreas, and the C in pancreas is calcium. Yep. So next question is, which of the following is not associated with appendicitis? So I'm just going to launch the polling now. Again, we'll give this like a minute. Okay, I'm going to end the polling there. And yeah, so like I said, there's lots, appendicitis comes with lots of weird, wonderful eponymous signs that someone will probably ask you about. But Murphy's sign is kind of the big one that's associated with the gallbladder. So with the gallbladder, the one you want to remember is Murphy's sign, yeah? Okay, so I've got a question here that says, how do you tell the difference between chronic and acute pancreatitis? Is it literally just calcification? So yes, chronic pancreatitis would be associated with calcification, but essentially it would, but the big thing that would differentiate is the history. So a first presentation of chronic pancreatitis would just be acute pancreatitis. What makes it chronic is these recurrent presentations, and then you would generally see kind of amylase levels that aren't quite as high as you would see in acute pancreatitis. But it's all in the name. It's down to their history and kind of what it's been like for them. it's not, if it's not just a one-off or a second-off presentation. If it's kind of not kind of 1 or 2 presentations, then you start thinking this is something chronic. Yep, so the next question here is, there we go. So 27-year-old man in A&E. Going to launch that now. Okay, I'm gonna end that there and share the result. Yeah. So the big kind of clues in this question are, so he's got epigastric pain and epigastric tenderness. It's pain radiating to the back. And the big one here is this bluish discoloration around the umbilicus. This is pointing towards Cullen's sign. So all of this is saying this is someone you're worried about, you're thinking about pancreatitis with, which is why you want to do an amylase on it, on this gentleman. But yeah, most of you all got that right. So let's go on to the next one. Oh, sorry. Let me just share those results from the last one. Oh no, sorry, what am I doing? Oops, sorry. Yeah. So I'm going to launch, if everyone's had a lot of time to read this, so we're going to run this for a minute again. But another 27-year-old male with abdominal pain. So I've got a question here that says, why are duodenal ulcers better with eating and gastric ulcers worse? So essentially it's because consuming food triggers essentially the secretion of hydrochloric acid in the stomach, which would irritate the lining and irritate the ulcer, which is why immediately after eating you have worse abdominal pain, classically in gastric ulcers. Whereas duodenal pain comes up, if you had duodenal ulcers, you'd have worse pain sometime after eating, because by the time the food gets let into the duodenum and you have all sorts of all the pancreatic juices entering the duodenum, that's when you'd start kind of irritating the duodenal lining and the ulcer consequently. So I'm going to start the polling there for this question. And we'll share the results. This was very impressive. One person for Buscopan, but by and large. And I think I've got one more question here. There we go. Oh, sorry. I'm going to launch this and going to run it for a minute again, if that's okay. Almost done. Like almost done. That's fine. You take your time. Okay, we're going to end it there. Yes, so this goes back down to our screening program, the screening program we looked at earlier, and it's worth it's worth kind of, this is one of the things that's worth kind of actually learning. So yes, it would be a 3-month ultrasound. So most of you got that right again. Those are all the questions I have there. Essentially, what I'm going to do is leave you on, oh yeah, I just really like this comic, but essentially things are hard, but by and large, you've got this, it'll be fine. And OSCEs are generally like, it's a weird exam to do, but you get through it and it gets easier as you go along. I just really like that comic. These are my sources. What I'm going to do is leave it on this slide for feedback, and I'm going to run through the questions in the Q&A section. So, how do I do that? What is the pointing sign? Good question. I should have looked that up before I started. Please look that up. So the next question I have here is, why is amylase not on the scoring system for pancreatitis? So it doesn't have it doesn't show, give you a prognosis for pancreatitis essentially. So the Glasgow scoring scale is kind of giving you an idea of the severity and the prognosis. And what essentially amylase doesn't kind of inform you more, give you more information than saying it is there and there is some pancreatic enzymes being secreted. Why is it right shoulder tip pain with cholecystitis? I would think this is more down to kind of diaphragmatic irritation again, this time on the right-hand side. What have I got? So the next one I've got is, are Cullen's and Gray Turner signs very late signs? Yes, they tend to be. So you tend to have kind of either retroperitoneal hemorrhage that's kind of tracking down the psoas, which is what's causing Gray Turner's sign. Or Cullen's sign is again kind of signs of hemorrhage. So they are fairly late and we tend not to see them very often. I've got another one that says, in the last case, pancreatitis without the bluish discoloration, it was sounding a lot like possible PUD. So I'm not sure if everyone can see these questions, but essentially it says, if you weren't talking about this, if you didn't have this Cullen sign in that question about pancreatitis, it would sound like a PUD, a peptic ulcer. And that's very true. I think the thing to remember with EMQs in medical school is that they're fairly formulaic, so they will make things fairly obvious. So they kind of, they're not, so generally when they're saying things like it's radiating to the back and there is this kind of sign, they tend to be kind of fairly on the nose with these things. But you're absolutely right. In real life, you probably wouldn't be having Cullen sign, and you're probably be doing a bunch of tests to make sure that it's pancreatitis and not and not sort of a peptic ulcer or perforation. You're absolutely right. But kind of in EMQ and SBA world, things are kind of a little bit more black and white, really. And I've got another question about foundation applications. Why did I choose Guys and Tommies? And if you are thinking of applying to Guys and St. Thomas's, it's a really, really good place to do an F1. I really enjoyed it. Got a massive group of F1s. People are generally really friendly. It's really well supported, absolutely considerate. I don't know if there's F1 cardiology jobs there though, but I would highly recommend F1 and Guys and Tommies. I had a really good time. But it's really down to you. The last question I have here is, with the last question, would he not also get antihypertensives for BP and see his GP? Absolutely, yes. Essentially, kind of, I think that what this question is trying to say is pick the kind of most pertinent answer. So the big thing that you want to make sure that you're doing. So absolutely, you would want this patient to be on antihypertensives. You would want them to be seeing the GP. But the big thing you want to be doing for these patients is getting them in 3 months' time to do surveillance on their aneurysm. Yeah. Well, if anyone has any more questions, I'll stick around for about a couple of minutes. Let me know. But otherwise, have a nice day and good luck with everything. Obviously, if you've got any questions, feel free to email me, or if you had any questions about F1, my email's on the slides. Oh, first line, I've got one that says, what is the first line investigation for diverticulitis? Quite a lot of the time it was a CT actually. They would come in, they'd get their, the usual bloods, and generally it was a CT that would confirm it. But again, you'd be doing the CT after considering kind of patient demographics, their presentation, whether they've got a background of diverticular disease, all that stuff. Sweet. Okay, well, have a nice day, guys. Bye-bye.